I don't think that it is expressed in nursing school that you can graduate and you can get a job in a new grad program and you can fail and get fired from your new grad program and not have a job anymore once you're a nurse. Hi guys, it's X. Welcome back to my channel. In today's video, I wanted to kind of talk about what you should be doing in clinical as a nursing student. And I know this is going to vary from semester to semester, school to school, but I absolutely love to Precept students. I always volunteer to Precept students, and lately I've just seen a couple of things that were so baffling to me that almost made me not want to take students for a while, just because I could not believe the audacity, I guess. Just like one day, I was actually a resource nurse. I was not a bedside nurse that day, so I did not actually get to take a student, but the students that I did see on our unit in our ICU were falling asleep, taking 3 to 4 breaks, which they usually don't do for this particular school, and not wanting to help when it came to cleaning up patient. And I was just kind of a little taken back, a little baffled, because I'm a nurse and I'm not too good to clean anyone's butt. Like, that is my job. So the fact that I saw a nursing student not wanting to help clean up a patient who had a bowel movement, I was just a little like, this is our job. This is what we do. It's not everything we do, but this is what we do. Also, just falling asleep at your clinical site, absolutely unacceptable. Everybody has their own personal things going on in life, schedules, working, but as somebody who worked at Starbucks and had to be up at 3 a.m., work from 4 a.m. to 12:30 p.m., go to clinical in a completely different city from 3 p.m. to 11 p.m. and wake up and do it all over the next day, I don't have sympathy for anybody to fall asleep at clinical. So I thought maybe I should just make a video of what I expect as a nurse for my nursing students, and like things and tips and tricks that can kind of help you get the best out of your clinical experience. So before I went into nursing school, I didn't know what nurses did. I thought we passed medication and took care of people, but I didn't know everything that entailed. I didn't understand until I finished nursing school and became an ICU nurse, PCU nurse, because I started off in PCU, like what our job actually was. And when I actually found that out, I fell in love with being a nurse, because prior to this, my dream was actually to be a police officer. And the reason why is because I wanted to be a detective. I wanted to solve crimes. I wanted to solve cases. And being an ICU nurse is kind of like that. You kind of have to critically think, put 2 and 2 together, put things together, and figure out what's going on with your patient when they can't speak to you all the time. So I kind of wanted to make this video to kind of give you a pathway or like a goal when you go to clinical. So like I said earlier in this video, obviously this is going to vary school to school, vary semester to semester, because a lot of schools will let you do one thing in one semester and won't let you in another. So this is kind of just general. I could tell you what I like, and I could tell you straight up what I don't like. What I love about precepting students: 1, it keeps me on my toes. It keeps me up to date on the knowledge. I have to know my drugs. I have to know my medications. I have to know the up-to-date evidence-based practice, obviously, because I'm teaching a student. And if I don't know my stuff, how can I pass on or teach my student? Also, to this day, I still learn things from my students. So I feel like it's kind of like a closed loop circle where I'm constantly learning, I have to be on top of it, and I am teaching somebody else. Because I'm teaching somebody else, I want to make sure that what I'm teaching is correct, factual, and up to date. So I love teaching for that reason. Also, I also know what it's like to be a nursing student and show up to a unit and you're so excited to learn, and the nurse that you're given doesn't want you. Strictly is like not happy that you're there with them today and doesn't want to work with you. And that is frustrating, especially when you're trying to learn and you really want to learn and they're just not about it. So you're like, great, not fun 8 to 12 hours that you're in clinical. So I love to take students because I understand what it feels like to show up to a unit and a nurse not want you. So that's another thing. I also love when my students want to learn. I love having people who are intuitive, having people who ask questions. And I don't think that there necessarily is such a stupid question. I mean, there can be, obviously. But I think stupid questions are like when you already know the answer or you just weren't paying attention and then you ask the question again and it's like, I already told you this or you should have known this. But I love when people have questions. Like one time, I had a patient with an EVD on hypertonic saline, ventilated, broken bones everywhere, splints everywhere, like boom, vat, everything. And I asked my nursing student, like, what questions do you have? Oh, I have none. Are you kidding me? I know you damn well you don't know anything about that EVD. I know damn well you know very minimal about that vent. Like, probably never seen a wound vac. Like, come on, ask me questions. I know you have them. Do not be shy. Like, hopefully you're working with a nurse who absolutely loves to precept just like me, but ask the questions because this is your time. Sometimes it drives me crazy when I see students who just stand around outside the room or they're standing at the computer all day or sitting at the computer researching all day. And it's like, no, your one-on-one time with me is more valuable than what you're gonna learn in that computer. I get that you have papers to write. I get that you have things that you have to answer to your professor, but I can give you that. So one thing that I cannot stand is when I have a student and I'm trying to teach them something and they're more focused about being on the computer. It's like, no, follow me around. Ask me questions, like, let's do this together. You are also not gonna learn by standing at the door. You're also not gonna learn by not putting your hands on your patient. I don't think that it is expressed in nursing school that you can graduate and you can get a job in a new grad program and you can fail and get fired from your new grad program and not have a job anymore once you're a nurse because you're not meeting the expectation of the hospital. I've got hired with numerous people in several jobs, like as a new grad or in another hospital in the ICU, like new program or transition program, who didn't make the cut, who were let go. Why? Because visibly they could see that at a nursing school, you're still not cutting it. Being in clinical is where you are gonna get the experience that you need to transition into being a nurse. Do not wait until the last minute. I can't tell you how many nursing students come to me in the 4th semester and I sometimes have to look at them and be like, wow, you're gonna start working in 3 months, because as soon as you graduate, usually they're in 4th semester when they come to me, it's like, you're gonna graduate and you still can't drop a medication. Like, you still can't hang a piggyback correctly. This is it. Like, you only get some hospitals. I think I got like 12 shifts. And when you think about it, we work 3 12s. Do the math. It ain't that many months that you have with a preceptor before you're on your own. And there's a lot of things that you don't want to have to learn on your own when nobody is there to help you because your preceptorship is done. So take the time in clinical to really hone in on your skills, learn things. If your nurse is not letting you do things, please advocate for yourself. I remember going to post-conference and some people were like, oh, I hung this drug today. Oh, I passed this med today. I was doing trach insertions, EVD insertions, like hang multiple drugs, doing multiple things because I actively sought it out. My critical care teacher in nursing school told me that you're gonna get out of clinical what you put in. If you actively go and seek out experiences, you will get them if you ask. But if you're just kind of standing around not doing anything or just waiting for your nurse to find you, I'm not gonna go look for my students. I'm sorry. If you're not following me and you're here to learn from me, I have patients to take care of, and they're my number one priority. Teaching my students is second. So if you're not following me around and you're just sitting at a computer, you're not gonna get the experience that you need. And sometimes if my student is not around me and I have something to do, I'm so focused and in my routine that I'll forget, like, oh crap, I shouldn't have handled that antibiotic. Like, my student could have done that. Sometimes I'll forget. So I'm like, I need that kind of little bit of a reminder too. But usually the students who are right there with me, right beside me, ready to do the things, get those experiences. But if I don't see you half the shift and you're on the computer and not following me, not asking me questions, like, all right, you're clearly not here for me, so go do your own thing. So with that being said, as a preceptor, every time I get a student, will usually ask the rest of the nurses on my unit, like, if you need an NG insertion, Foley catheter, IV, anything that my student can do, let me know. And that's usually how we'll get things. Like, other nurses will be like, hey, I'm so busy today, I have an NG tube that needs to be placed. Like, does your student want to do it? Absolutely. What room? Let's go. So you need to actively seek out those things and you will get them. Another thing that sadly embarrassing, I am sad to admit, but I don't know why it wasn't until my second semester that I realized nurses, like, everything we do obviously has to have a rationale, but I was like, oh, like I think I was so focused on fundamentals and just memorizing things that I didn't realize that we were learning, like, thing that you have to, if something happens, you have to figure out why and then go and like remediate that. I don't know if I'm explaining this right, but obviously, like, everything that we do has an intervention and it has a rationale, and you need to know the pros and cons. One thing I will tell you that I think you will get stuck on in nursing school, but when you transition as a nurse, you'll see is a little bit different. Nursing school is there to teach you a basic, this is how things are done for every disease process, right? But not every patient is a cookie cutter. You cannot apply everything to like one situation to a patient. Let's say heart attack. Okay, so if you have a heart attack, you need to be on these drugs, these antiplatelets, beta blockers, whatever, morphine, pain medicine. But let's say you have multiple comorbidities. Like, one time I had a patient who had a heart attack but then stroked out and was on a beta blocker, but we needed the blood pressure a certain parameter. Like, you have to see the whole picture. I have to give the metoprolol for the heart, but I also have to keep the blood pressure in a certain range because of the stroke. So that's kind of things that you get nitty gritty on, and that's kind of things as you learn in your career that you will have to adjust. You can't cookie cut each patient. Like, yes, there are guidelines for every single disease process, but you have to shape and mold it as you go along because every single patient is different. Every single patient has different comorbidities, different problems, and you just can't put a patient in a box and expect this is what we do and this is how we do it. And every hospital, every facility, every provider treats their patient differently. So in school, yes, for NCLEX, for those purposes, do those things. But once you get to practice, you really have to know your patient. And being in the ICU, I'm kind of lucky because I have monitors all the time. So I know my patients, like, vital signs to a T. Like, for instance, once I had a patient consistently, temperature 98 point something, heart rate 90s to 100, blood pressure 150s. Next day I show up, completely different picture. Tacky to the 100s to the 110s. Still on the normal side. Temperature now 96 to 97. Blood pressure now into the low hundreds. Mentally, completely different. Not as bubbly, not as cheerful. So even though all these vital signs are normal, this is not normal for my patient. And those are things that you kind of have to learn as you go because everything is still normal, but from one day to the next, it completely changed. So that is something that you will learn as you go on through your career. The next thing that I really want to talk about, besides actively asking your nurse, like, hey, can you ask other nurses, if there's anything that needs to be done, whether it's Foley, IV, whatever, if it's in your scope of practice, in your semester, whatever your school allows, like actively ask, hey, can we make sure we try to do these today? Or have goals, like go and be like, hi, like I never put in a Foley today, so I was just wondering if the opportunity comes up, like, can I do that? Perfect situation. Like, let your nurse know what you can and can't do. I remember when I was in clinical, nurses used to ask me like, oh, what semester are you? So they could kind of gauge what I was capable of. But I don't understand now that I'm a nurse and now that I precept, how or why they knew that, because I don't know what your school requires. Like, we work with some accelerated BSN programs, and their second semester is going to vary very differently than my ADN program versus my BSN program. Like every school that I work with is very different. So I'm not going to be able to know what you are allowed to do unless you tell me. So, or if I ask like, hey, can you do this? And you tell me no. So actively seek out opportunities where you can, knowing what's in your scope at the level of nursing school that you are in. Another thing that I want to talk about was knowing your labs and your disease processes. I think that's a little bit hard when you're in nursing school and there's so much information thrown at you. I don't typically expect you to know every single thing, but one thing that I wish I would have done earlier on was put more pieces together. Like today I had a student who was asking me like, oh, this person is here for hyponatremia. Well, what is her plan? And I'm like, well, first off, we have to figure out what is causing this hyponatremia. Is this a chronic condition? Why does this person have hyponatremia? There's so many different reasons why someone can have hyponatremia. So what is the reason for this person? Have to look at the history, have to look at that. So don't just look at an abnormal electrolyte and think, okay, it's abnormal. All right, you write it down to put on your care plan, but try to figure out early on while you're still in school and you're still learning, like, what disease process does this patient have? Could the electrolyte abnormality be related to the disease process that there was? Oh, perfect example. So one time I had a young patient, it was raining, got in a car accident, and had a head injury, and ended up in the intensive care unit. And my student asked me, why are they on hypertonic saline? And another thing, I teach by what, why. So I want to know, if you ask me a question, I'm going to ask, why do you think? I'm not asking in a condescending fashion. It may come off that way, but I want to know what you're thinking and why you're thinking that. And then I'll tell you what we do and why we do it, because for everything we do, there's a rationale. So I asked my student, why do you think they're on hypertonic saline? I don't know. Well, they have low salt. Okay, but why? And kind of blank stare, I don't know. And I was like, why is the person here? Car accident. Okay. So why, like, what's the injury? Traumatic brain injury. Okay. I'm trying to probe it out of you. I'm not the type of preceptor that's going to give you the answer. I want you to think, and I precept my transition nurses, meaning like if they come from another floor to the ICU, I precept them the exact same way. I'm not going to give you the answer. I want you to think, and I want to see your thought process so that I know how much kind of training you need or like where you're at. So my student at this point could not get the answer. She was still confused. And so I told her, I was like, this is a healthy young woman. Like, what condition in her life do you think would cause hyponatremia that would cause her to be in the ICU? No answer. Why? Because the answer, at least to me, now that obviously I'm experienced, is simple. There's a traumatic brain injury. There is edema. We need the swelling down. We need to give hypertonic saline because we have sodium goals that are above. There's no reason, there's no hyponatremic reason. Like, it's not like this girl randomly had a low sodium which made her cause into a car accident and then caused her to be in the ICU, and now we're on a hypotonic to treat the low sodium. No, it's obvious. Traumatic brain injury, we have swelling in the brain, need hypertonic to decrease swelling. There you go. This is what I was trying to probe out of the student. So early on, electrolytes, very, very important. One thing that I had a coworker, her and I started at the same hospital at the same time. trying to get into the ICU at this hospital, because we both got hired into the ICU, but it was a transition program, so they made us work the floor before going in. And her preceptor told her, we don't monitor electrolytes, that's for the doctor. Absolutely not true. You as a nurse are the last line of defense before the patient. Like, you are the last person to protect the patient. You're the one to give you the medication. If the doctor writes the order, you are the one that carries it out. So I would absolutely not bank on my provider to look at everything. The provider has, God only knows, up to 20, 30 patients. You as a nurse, depending on where you work, will probably have 2 to 6. Sadly, if you're in another state and not in California, probably have 8 to 10. I don't know. So those electrolytes, those labs are your problem. They are your issue. So if something is abnormal, look at trends and figure out why, because it is your job. Next, I would start to suggest medication, getting to know them. And especially if you want to advance your career to nurse practitioner or so on, I would definitely start looking at dosages and looking at whether or not, like, what is the norm or what's prescribed for what disease process. I started off as a new grad on a PCU floor. And I floated one time, I don't know, 6 months, a year into my career to a tele floor. And I remember the day shift nurse being so irritated with me because I didn't know, I was on a tele floor, when the patient had a last bowel movement and what anticoagulation they were on. And I used to have this mindset where if the patient did not get the drug at night, I didn't care what was on the days. And that is such the wrong mindset to have. Now that obviously I'm more into my career and more like established as a nurse, I get why this was so important. But and why all the drugs that are on the profile are important. But at that time, I was just like, if I didn't give it, I didn't look, like, I don't know. And I didn't understand at this point why this tele nurse cared so much. Like, I don't know, but hello, they're here for telemetry. Like, they can pass out or die in code if they are straining and having a bowel movement. Like, a lot of patients actually have syncopal episodes and bradycardia, can go asystole by taking a poop. So I was like, oh, okay. Noted. Now I understand why she was asking me. Well, if they're there for AFib or they're there for chest pain, like, did they get stents? Are they on anticoagulation? Like, are they on dual platelet therapy? Do they have Eliquis or Xarelto for their AFib? Like, now I get why she was so frustrated with me for not knowing, but a lot of these medications were giving during the day and I simply didn't look. But now I get it. Now I understand, now that I've been a nurse longer, like, these are things that you need to know. And just because you did not get it, it's not on your shift, you should know it's on your patient's profile. I actually, on my brain, have neurorespiratory, cardiac, like all the symptoms, all the systems. And I have medications. So my last advice to you is show up on time. Do not be late. That's my biggest pet peeve. So I'm going to emphasize that. Do not be sleepy. Do not look sloppy. Show up on time, eager, ready to work. Have a list of things that maybe for yourself. I haven't done this. Ask your nurse, can I do this? And if you feel like you're not getting the experience that you want, speak up. I used to fight with my nurses all the time because I'm like, I just did not. Don't let anyone bully you. Don't let anyone look down on you. Yes, you are a student, but you are here to learn and you are here to get the best experience so that when you move on to your career, you are the best you can be. And this is your time to learn. Clinical. Do not waste time. Do not sit there. Do not just be on your phone. Do not just stand outside. Put the gloves on and go help turn the patient. Put the gloves on, help clean up the patient. Help them get up. Help as much as you can. Like I said in the beginning, you're gonna get out what you put in. Clinical can be very boring when you're there not doing a damn thing. I used to walk around and ask other nurses, like, do you guys need help? Because I don't want to sit here and being alone. And one thing that sometimes I will not allow my coworkers to do to my students is like, oh, can they help me clean up this patient? Can they help me, boost this patient up? Like, yes, that is our job, but you're not at fourth semester there just for that. Like, if I have something more important to do, like pass meds or put in an IV or something, I'm not gonna like be like, oh yeah, it's a student, they could do your octa checks, they could do this. Like, no, I want you to get the full experience and do everything. So make sure you know your norms, try to start putting pieces together. I know it's a lot overwhelming. It's very overwhelming when you have all this info and like you are still learning, but that's why take this opportunity as like your pre-job training, because who knows, once you start working, you might not get that much training. I think my first time working as a new grad, I think I was supposed to get like 2 months with a preceptor, but calculate that. That's 3 12s. So 3 times 4, that's 12 shifts, 24 shifts. 24 shifts in 2 months. That's all you have before you're on your own. So take that into consideration and remember, try to get out everything you can. Know your labs, know your norms, know your disease processes, know that you cannot cookie cut a patient. There are multiple things going on. You have to look at the big picture, not just put a patient in a box. Start looking at your norms for medication. Start learning what your reversals are for certain medications. Like, for instance, if you have Pradaxa, Praxipine. If you have Rocuronium, Sugamidex. If you have aspirin, what are you doing to reverse that if the patient falls and bleeds? Like, just start learning drugs and what their norms are, what they're usually prescribed for, and disease processes. And know that you have to ultimately know your patient the best and try to be the best nurse you can and try to advocate the best you can. So those are things that I expect from my students. I absolutely love. I cannot stand when I have a student who just wants to stand outside, who does not put gloves on, who stands with their hands behind her back outside the door, who's on the computer and not paying attention to me. What I absolutely love is a student who comes to clinical eager to work, has a ton of questions that they want to learn, shows me that they want to be there, and is willing to do whatever to get their best experience. I love. I usually am like, give me your best student, give me your most excited student, because I love having students who really want to be there and who really want to learn. Anyway, I hope you guys got whatever you needed out of this video. Hopefully your clinicals go very well, and let me know down below if you have any questions. Bye.